we're going to talk about emerging treatments, sort of. This is my disclosure slide. My most complicated relationship is really with the Tourette Syndrome Association, where I get grant funding from them. They pay me to do talks as part of the CDC kind of outreach program, and I've written with others, many others, books about Tourette syndrome, and I get royalties there. My experience with industry is kind of long gone. They provided drug and placebo for kind of large randomized controlled trials. I'm going to talk a little bit about Oliver Sacks. You've heard a little bit about him already. Then I talk a little bit about the giants. One of the things I've recognized at this meeting is that there are many young people here. And just to review a little bit kind of the previous international meetings and the people who were part of those meetings, some of whom are still here, but many of them who are not here at this meeting, and just so that everybody kind of gets a sense of a shared history of where we've been in terms of Tourette syndrome and its treatment. And then really walk through kind of what's happening with treatment, and then talk about really what the future of treatment is. So Oliver was born in 1933. He got his medical degree from Oxford at Queen's College. He did his residency in the United States and ultimately had academic appointments at Columbia, NYU, and the University of Warwick. He's probably best known author for a variety of different books, including The Man Who Mistook His Wife for a Hat, and his most recent book, which is On the Move, and it has a great cover photo which shows him sitting on the back of a motorcycle. He looked like a pretty hunky guy, actually, back in those days. And then the one thing I remember most about him was he would always talk about Witty Ticky Ray. So if you've never really read about Witty Ticky Ray and how he could be witty and ticky and love that aspect of himself, but it didn't work very well with the rest of his life, but that's when he put medicine on board. And when he put medicine on board, he kind of became stable and solid and not a whole lot of fun. And he really talked about that tension between being under control and being yourself on some level. These are the giants as I recall them, and I think I'm obviously going to leave somebody out, and so to capture it on tape for posterity, if you have a giant from your country or from your clinic, we probably ought to scream them out. Yeah, I got Mary already. These are the ones who are not here. So Arthur and Elaine Shapiro, who I think really kind of picked up the thread of Tourette being a neurologic disorder. Don Cohen, who was my mentor at the Yale Child Study Center, probably made child psychiatry as international an experience for us in the United States. A big leader. Helmut Remschmidt has been in the Tourette team forever. Harvey Singer was a mentor of mine. Neil Swerdlow ran the scientific advisory board at the TSA for a decade and was responsible for the genetics initiative, the neuroimaging initiative, the behavioral initiative that came out of the TSA. David Pauls and the folks at Yale and others internationally, Ben van Vettering and Hoytnik from Europe participated in the early genetic studies. Roger Curlin, who's not here today but still active. And I put David Cummings down because David Cummings was talking about polygenic inheritance a long time ago, and we were scoffing. And he said a bunch of other stuff too, but yesterday we found out polygenic is where it's at, and so he kind of set the tone in some particular way. Also, we're missing Gerd Strand. Just died June 1. And then these are the giants who are here. Jim's here, Mary's here, Joe Jankovic, and Danielle from Europe. And again, if there are people that I missed, please scream out their name, because I'm sure I missed somebody. All right. Now, you are all the folks who are the giants to be. So look forward to the next international meeting where we can hear about the next great things that happen in Tourette syndrome. Okay, a little historical context. So Tourette worked with Charcot, and Freud was a contemporary at that time, and they were working on the movement disorders, including hysterical movement disorders. And Charcot and Tourette identified a group of patients that had these kind of unusual movements, and Charcot said to Tourette, write it up, and we'll let you name this disorder after yourself. And that's pretty much what happened. And at that time, there were no real treatments available, but this Freud guy was getting hysterical movement disorders better by doing dream interpretation and free association. So all the Tourette syndrome patients went over to Freud, and he started doing dream interpretation and free association, and it became a psychiatric disorder, a psychological condition. And then in 1961, or thereabouts, people began to use antipsychotic or neuroleptic agents in Tourette syndrome patients, and pretty much overnight, it shifted from being a psychological condition into a neurologic condition. And the one thing about that is that the people who had it conceptualized as a psychological condition weren't quite ready for it to be switched out of their bailiwick into the neurologic world. And there were all kinds of catastrophic pronouncements made with the advent of a neurologic approach, a medication approach predominantly, to what was considered at that time a psychological condition. It was essentially the idea that if you use medicine to make the symptoms go away, you're essentially leaving the person with the psychological burden of the illness without really going to the core psychological processes. And on some level, it was viewed as inhumane. But I think we won the day on the neurologic side with Tourette. And then in the mid-1980s, after Tourette kind of had a treatment, essentially Oliver Sacks and the Tourette Syndrome Association began to identify people everywhere as ticking and twitching. So Oliver would talk about riding the subway, walking the streets of New York. I now walk the streets of New York, and I get to see people ticking all the time. It's a very common sight. And so the other thing that was happening clinically is you would see someone with a tic disorder, and you would notice that one or another of that child's parents would be ticking too. And so you began to say, oh my goodness, this runs in families, and it runs in each generation, must be autosomal dominant. So family studies began to happen in the mid-1980s, and at that time, they identified psychiatric comorbidity. David Cummings identified a variety of other comorbidities, but the ones that seemed to be the most true were ADHD and OCD. And so at that point, it came back again in mid-ground to be kind of a neuropsychiatric disorder with a kind of strong neurologic underpinning, strong genetic diathesis. And I was involved in some of the early twin studies, and one of the things that we found with the identical twins is that they were concordant for tics, but they weren't concordant for severity. So that while you could get the gene and you would express the condition, you might have a different level of severity than your co-twin who should be very close to identical. And so this now becomes a great psychiatric disorder, neuropsychiatric disorder, where you've got a genetic basis to it, a strong response to environment, a fairly robust and interesting prototypic condition to study. And now with the development of behavioral strategies for reducing tic severity, we now have kind of filled out the idea or the conceptual model of Tourette to be one that's neurologic and genetic, sensitive to the environment, and also has behavioral and functional components to it. And so that our treatments, if we're really going to think about Tourette in a complex way, has to span the neurology of it, the environmental aspects of it, and the behavioral and functional components too. One of my close colleagues says the reason why neuroscience is so important is because it leads us to understand how really important the environment is. And I think that's kind of where we are with Tourette today. When I think about all the patients that I've seen over time with Tourette syndrome, I break them into historical cohorts. And essentially, people who are in their 40s, over 40 or 50, these are people who really didn't benefit from the awareness of Tourette when they were younger. The next group is really a group that got clobbered with antipsychotics. The goal then was to make everything go away. And so many of them lost good chunks of their childhood, adolescence, and young adulthood before their tics began to wane and they came off medicine. I grew up professionally during a period of time when we were telling kids you can't control it, so don't bother. And what was interesting about that is that in addition to not managing their tics very well, they didn't manage their anger very well, their emotions very well, their behavior very well. And so we on some level, iatrogenically supported a group of patients, a cohort of patients who had limited emotion and behavior control above and beyond that might be explained by their Tourette syndrome. And we moved from that, I think, relatively quickly to something that's, you have Tourette, but it really is about those other conditions that affect you over the lifetime that are going to make it difficult for you. So we not only have to worry about the tics, but we have to take care of the co-occurring conditions. And now I think we're at a place where we're really understanding the value of tics, the value of comorbidity, the value of taking responsibility for your growth and development, staying on track and doing as very best you can in terms of getting an education, being a good friend to others, contributing to the community. And that's what we see really with the younger people now with Tourette syndrome, is they've got a condition that impacts them during childhood and adolescence. But if they stay focused on the core elements of a powerful and evolving identity, they do pretty dang well as they move into adulthood. Okay. So these are the somatic treatments. There's a million of them. And if you did the neurotransmitter thing on Thursday, you began to see that every neurotransmitter has something to do with Tourette, and that every neurotransmitter has probably a zillion different targets one way or another. And the whole idea is to organize drugs around one of those targets to begin to have an impact somewhere within the network or pathway. And these are just a bunch of examples of recent clinical trials that have been completed or trials that are underway. And again, all looking at some way to modulate the brain circuitry that has something to do with Tourette. The botulinum toxin is really the injectable form. Glutamate's been a popular target. So Harvey Singer's worked with D-serine and riluzole. The EP743 is a very interesting drug, thinking about kind of mitochondrial kind of mechanisms that are involved in Tourette. And because of the family that Matt State talked about yesterday, histamine has become a hot topic. And so there are pharmaceutical companies that are dusting off their histamine agents to see whether they might have some utility either in this condition or other movement disorders. Tourette has always been a popular place for alternative and complementary treatments. So the plum blossom needle therapy, randomized controlled trial underway. This is the plum blossom, and it's got little needles on the end, and you just tap it on the affected area, and it brings a little blood and sensation to the surface. And it's kind of acupuncture light of sort. Omega-3 has been studied. Barbara Coffey worked on that one with Vilma Gabe. NAC, Michael Block worked on that at the Yale Child Study Center. Again, as I mentioned, the histamine antagonists are popular based on kind of Matt's genetics work. This is a very interesting drug as far as I'm concerned, VMAT2, looking at a way to decrease the release of dopamine by inhibiting the transporter, the vesicular transporter. Again, another study was done with an anticonvulsant. Most anticonvulsants get tried at some point or another with Tourette. And I'm going to talk about the oral orthotic, the dental treatment this afternoon, and go into more detail there. We recently reviewed all of the different brain stimulation strategies for neuropsychiatric disorders. And it starts with as old-fashioned a drug as old-fashioned strategy as ECT. And it goes all the way down now to strategies where you're placing electrodes on the dura, so you're actually not going inside the brain per se, and using stimulation strategies that really sit at the level of the cortex. So this is just extremely hot and interesting, and the goal is really to find ways to stimulate parts of the brain that we believe are affected without really necessarily getting into the position where you're going into brain parenchyma per se. And then we have the behavioral treatments. this started a long time ago. When I talked to some behavioral psychologists when we were doing the CBIT study, they would look at me and say, like, I've been doing that for 20 years. Why are you guys just catching on now? And it was interesting. I think it had to do with that evolution from a psychological disorder to a neurologic disorder. And then once it became a neurologic disorder, it became really difficult to begin to think about moving it back into the behavioral realm. There was the thought that if you begin to think about it as a behavioral disorder, a disorder that's responsive to behavioral interventions, you're essentially going back to the days of Freud. And I don't think that's actually what we're doing. We're kind of moving into the future with a very, I think, much smarter view about how the brain learns and shapes itself over time. And I think the behavior therapy actually takes advantage of that. And some of the studies that I've seen presented here today really do, I think, highlight that brain learning component, that plasticity that's part of the Tourette syndrome phenotype. And CBIT, I think, works very well within that model. The Tourette syndrome had a scientific review a couple of years ago, and one of the things that came out of that scientific review was, you know, you guys actually have a really good treatment, and what you ought to be doing is pushing it really, really hard, because it is the kind of thing right now that's efficacious, it's useful across the age span, but you don't have all the people out there that you need to be able to do it, and so you have to find some way to get this treatment accessible to the many people who could benefit from it. As I was mentioning in the break time, I think that CBIT is a terrific intervention for physicians. How many physicians are here? How many psychologists? Yeah, this is just for the physicians. You can be kind of stupid and do this intervention. So, as a matter of fact, when we were doing this trial, I couldn't get my psychologist to want to do this treatment because it didn't have enough emotion in it. They really wanted to talk and relate and kind of generate affect. And physicians don't like to do that. They want to get in the room, they want to see the patient, and then they want to get out. And so I think this is an excellent treatment because if you think about it as a behavioral treatment, you can do it relatively quickly. So I'll give you an example. I had a 6-year-old boy, tongue thrusting tics. His solution was classic 6. He didn't get in trouble for the tic. He got in trouble because he put his hands in his mouth. Get your hands out of your mouth, get your hands out of your mouth, get your hands out of your mouth. He was a nervous wreck when I saw him. And so I said, oh, can you do this? And can you press your tongue against that fleshy part of your finger? He said, yes. I said, do it now. Mom and Dad, can you help him practice that at home? That intervention probably took 1.5 minutes. That's why I say it's physician friendly. I didn't do psychoed. I didn't do awareness training. I didn't do relaxation training. I taught him a competing response for a very disruptive tic, and it didn't take very long at all. But I understand behavioral approaches, and I understand how CBIT works. But if we could get physicians to really understand that it isn't a very complicated treatment to implement, I think with that front line with pediatricians who begin to see kids ticking, if they were able to teach those competing responses, we would decrease the numbers of kids that feel like they have to see neurology and psychiatry and psychology. And part of our goal with the dissemination of CBIT is really to get it to a place where on some level it becomes more totally medicalized and gets taken out of the psychological or psychiatric arena completely. So as I mentioned, we've had these changing conceptions, and with the advent of a behavioral treatment, we really do have to understand how this is a condition that is very sensitive both to environmental forces but also to behavioral interventions. We hear a lot about what makes tics better and what makes tics worse. But excitement, we didn't hear much about excitement, but excitement is terrible for tics. The classic example that I run into is the kid gets diagnosed in November. The family is reading everything on the internet until they finally settle down in April. And then they decide in May on their visit with me that they're going to celebrate the fact that they've made it through the school year by going to Disneyland. And I say, no, you're not. You're not going to Disneyland, because his tics will explode while he's waiting in line for the ride. I said, preferentially, you should go fishing. And in a lake where there are no fish. Because if he catches a fish, he'll get excited and it'll make the tics worse. All right, so that's the model for what makes tics better and worse. And if you think about it that way, a lot of the old tales that we used to tell, like kids hold on to their tics all day at school and then they release them like it's stored up goo. Probably not. During the day, they are involved in calm, focused activities, and when they come home and relax and they blow off steam, they're not involved in calm, focused activities. They're excited. They're overstimulated. They didn't hold them on to all day. They just went from a different brain place, if you will, after school period as opposed to during the school day. So if I could wish for any kid, it's to be in that zone 24/7, because when they're in that kind of mental zone, they don't tic very much. All right. So we also had to kind of justify thinking about this as a behavioral treatment. And the most interesting thing for me was how many adults with Tourette, once we began to explain the treatment to them, said things to us like, I've been doing that for years. And I said, well, okay, so what have you been doing? And so we got many good examples of strategies for managing tics that adults used and got incorporated actually into the manual. So in addition to it being kind of theoretically crisp and clean, it also had the value of experienced Tourette syndrome patients thrown in. And then we added the functional component to habit reversal, which I think is a very important component of the treatment and something that is quite physician friendly. And essentially the functional component is focusing on how inadvertently, when kids are symptomatic, the world responds to them in a way that unwittingly reinforces tic severity. And it reinforces tic severity in a couple of ways. One, when kids are extremely symptomatic, parents' hearts are broken, they give them a ton of attention, they give them back rubs, they make cookies for them, they do all kinds of things at the moment of peak severity that reinforce peak severity. Plus, when are tics the worst is when kids are doing homework. And when the kid begins to do homework and his tics get worse, the family says, oh my goodness, it breaks my heart to see you having to do the homework. So I tell you what, why don't you stop doing the homework, we'll go make some cookies, and I'll write a letter to the teacher so that you don't have to complete your homework. That set, if you will, of responses which are so human and so intuitively correct from a strictly behavioral point of view end up rewarding and reinforcing tic severity over time. So part of the intervention was to work with families to be spot on in terms of how they interact with their kids around moments of tic severity. I think you saw a slide earlier in the week of all the different clinical trials. This clinical trial, which was really done in two pieces, an adult and a child one, included 248 subjects, largest Tourette syndrome study from a treatment point of view ever. So on some level, we have the most data about a behavioral treatment, much more data than we do about pharmacotherapy. I think the risperidone trial was under 40 subjects, for example, and yet risperidone is a staple in terms of our strategy for reducing tic severity. This is the responder status. It works. It beats the control treatment. But still, many patients don't benefit from it. So part of what we're going to need to do is figure out how to make it more effective for the wide variety of people who wouldn't necessarily benefit from the first straightforward shot at it. I remember patient number 1 very well. He had moderate to severe Tourette syndrome. And once he got treated, he looked pretty dang good. So what have we been doing? Well, we've been adapting it for younger kids. This was an interesting endeavor. We thought we were going to have to train parents mostly in this, but the kids actually got the concept of habit reversal. So if 4-year-olds and 5-year-olds can figure out habit reversal, I think physicians can figure it out too. We've also developed a strategy to be used in neurology and in primary care. There's a poster out there now about how we've been training occupational therapists. Occupational therapists are part of the primary care system, so it'll be much easier for pediatricians to refer to occupational therapists who I think understand the body and put their hands on their body in a way that I think is very appropriate for this treatment. And I think it is an avenue. We're also going to be developing outreach materials for occupational therapists so that the ophthalmologists who take care of the eye blinkers and the ENT doctors who take care of the sniffers and snorters and the allergy kids, the pulmonologists who deal with the kids with chronic cough, all of them can begin to know that those disorders that they see as part of their specialty are part of this syndrome, and that there's occupational therapists nearby who can do the work. Mike Himley and Doug Woods have worked on telemedicine, and I think you may have seen an opportunity to look at the Tic Helper out there, which is an online version. So lots going on. So what does this all mean for the future of TS treatment? It's a huge change in advice. So in the bad old days, we used to say, just ignore your tics. Now we're saying, please, please become exquisitely aware of them. We used to say you can't control them, so why bother? And now we're saying, it's really important that you learn how to manage your tics. We still say don't punish, but what we're really invested in is let's reward them for developing strategies to manage tics. We used to say behavioral treatments don't work. I remember when we talked about if you do behavioral treatments, that urge is going to get to the point where your head might pop off. And certainly patients have described that from kind of old-fashioned suppression strategies. Now we're saying behavioral strategies work. Let's teach you how to use them. Don't try to suppress. We're saying, yeah, I don't really want you to do what I call white-knuckle suppression, which is total body tensing. I want you to get ahead of the tic. I want you to work around the tic. I want you to outsmart your tic. Or as Duncan McKinley says, I want you to get up in the morning before your tics do, because if the tics get up before you do, you're toast. Suppression versus premonitory urges probably does in the short term. I think there's some data to suggest that over time, with good management, the premonitory urges begin to fade away. New tics develop when they fade away. This was one of my favorites. This is a leftover principle from the psychodynamic psychoanalytic era. It was this idea that if you pushed a psychiatric symptom down here, it would pop up in a new form over here because you had this psychic goo that was kind of messy. And I don't think we've actually seen this with Tourette. And then the other thing about our old treatment strategies is sit back and let me treat you. And what we're doing with this behavioral treatment is, time to step up, let's get going, let's engage you in a process of taking this problem on and making a life for yourself. So new treatment paradigms, you have to be kind of ready to reduce tic severity. And I've talked to a lot of kids who aren't quite ready and a lot of families who aren't quite ready to kind of embrace this idea. Got to manage the comorbidity, of course. It seems like it's much more difficult if you've got OCD or you got ADHD to actually engage in a behavioral treatment, so managing some of those issues is really important. We talk with families now about the CBIT lifestyle, which is really how to live with a person who has Tourette without inadvertently reinforcing or facilitating escape from responsibilities. That lifestyle is something that if you were to begin it early, it would really turn into a pathway for living for kids and families over time that is a productive way of living in general. You can do CBIT alone, you can do CBIT plus meds, you can do med plus CBIT, and we've even had the experience of teaching some kids who are on meds where you can do the CBIT and you can begin to wean them from antipsychotic medicine, which is a nice deal. So as we found out yesterday, we really are on the verge of discovery, right? We're just this far away from finding the genes. I kind of think we are, actually. I think you're going to do it. I think you are close. We've heard it before, right? We've heard it before. The neuroscience stuff, so exciting. I had a great time at this meeting. Imaging, the animal models. I remember last scientific conference is like, well, we don't have any animal models. It'd be really nice to have an animal model. It's too bad we don't have an animal model. Now, I think that we presented 4 yesterday. A very exciting time in terms of animal models. And, we have a range of treatment for everybody, all the way from kind of CBIT in a preventative early intervention mode up to DBS for those people who may have escaped those treatment opportunities, those older adults who really have severe symptoms and complicated experiences. So with that, I'll quit. Take comments, questions? Joe.
John, first of all, congratulations on an excellent lecture, and thank you so much for listing me among the giants. As someone who is vertically challenged, I have never been called a giant, so I really appreciate that. But since this is the only talk on emerging therapies during the whole symposium, I think it's important to point out there are some other treatments besides the ones that you listed, and you listed most of them. You, for example, listed ecopipam, which is an important advance. It's a D1 antagonist that might be, very effective. You alluded to botulinum toxin, although you said apobotulinum toxin, that just refers to one type of botulinum toxin, yeah. But there are 4 types, and all botulinum toxins can be very effective for the focal tics, and especially for the premonitory sensation. But there are a number of other pharmacologic, treatments that I think deserve attention. For example, you mentioned VMAT2 inhibitors. You noted the NBI drug, which is one example of a VMAT2 inhibitor. But there's another one called SD809, which is a very important VMAT2 inhibitor. It's a that's a deuterated tetrabenazine. As you know, I'm very interested in tetrabenazine because it's not only a very effective anti-dopaminergic drug by depleting dopamine, it is also much safer than any typical or atypical neuroleptic. It does not cause tardive dyskinesia, has a number of other advantages. So I just want to point out that there are a number of studies currently underway that look at new pharmacologic treatments, and those of us who are involved in clinical care of patients with Tourette syndrome, yes, we believe in CBIT, and I'm glad that you pointed out that behavioral therapy should be medicalized, and I think it's a very important point. But in most cases, at least that I see, these patients require more than behavioral therapy, and maybe I see more severe cases, and therefore pharmacologic therapy is very important, and I think we should spend a little bit more time on pharmacological therapy. And I just mentioned some of the new, emerging treatments that I think are important to highlight.
Thanks very much. We talked about this yesterday. I actually went through clinicaltrials.gov, and so there may be some of these compounds not listed there. But if they're not listed there, those sponsors better get that drug on clinicaltrials.gov pretty soon.
All the ones that I mentioned are registered in
clinicaltrials.gov. Then that's my error. Yes.
Thank you so much for a really interesting talk and great overview. And it's actually really awesome to be able to see you talk in person because I've watched many of your talks on the web. It's just as exciting, if not more exciting for me. But I had a question about the old versus new advice slide that you had. And I always struggle with telling families to ignore tics versus focus on the tics. And it seems like on your slide that there's no middle ground discussed there. And when tics aren't bothersome to the child and they're not being noticed at school, how much do you push this CBIT lifestyle philosophy?
Well, the CBIT lifestyle is hygienic interaction strategies, if you will. And so I'd push that to the max. When I talk about awareness of tics, it's not like you focus on them or engage the child around them, but you notice what's triggering them. You begin to think about when they're better, when they're worse as a parent. You become a student of your child's tics, if you will, so that you can then begin to think about behavioral strategies that you can use with your child to disrupt that kind of reinforcing pattern, if you will. So I want parents to be exquisitely aware of their kids' tics, but without necessarily engaging their kid in the process. So does that make sense?
So you're changing parents' behavior, basically, but not giving the child competing responses if it doesn't bother the child.
Well, again, I like competing responses when they're really cleanly targeted, like the 6-year-old. And I think families can begin to think about that once they learn the behavioral principles too, and they can actually do some of that stuff. But we have seen families that don't have that CBIT lifestyle in place who try and begin to intervene, and they miss. And so on some level, if you ought to get certified in the CBIT lifestyle probably, or have a good coach nearby so you can kind of check it out and make sure that you're not focusing on competing responses that are actually not appropriate, if you will. But again, I think the old days, we just said ignore the tics, and for many years, kids, I would have families, you can't believe how terrible the dinner table is. We ignore his tics, and he's screeching and has problems, and the families feel completely powerless to do anything about it. And what I'm saying is, no, there is a way to kind of engage the process, not the child around the tics, but engage the process, where you can kind of bring some kind of peace and quiet on some level to your home again. And I think that's the message, is empowering people as opposed to putting people in a passive position with respect to tics.
Great, thank you.
I was startled by your comment that kids shouldn't go to Disney World, or that they should stay in school all day. Just the whole morning about quality of life and some level of tic acceptance might be warranted, and I just wondered what you thought about that.
Oh yeah, the point is excitement is troublesome as stress, and that's the whole point of that story. Kids should go to Disneyland, and if their tics get worse, it might be worth it. But many families go to Disneyland thinking they're doing something positive for their youngster, and then get shocked when it's really a very difficult time, and they come home early. And so unless they understand that that's part of the process, that tics are really reactive in that way, they get disappointed.
I have a small addition, because I love that you talk about from a patient's point of view and behavioral treatment, but I couldn't help but notice that all your list of the grades were almost all MDs. And from a patient point of view, and also from someone who works for a patient's organization, I would like to add Doug Woods and Cara Vordelle to that.
The who?
Doug Woods and Cara Vordelle, because they are really working really hard to get these behavioral treatments out. And I think for patients, that is a really, really important thing. And especially when it comes to Cara, she brought exposure to Tourette's, basically. And for me personally, and a lot of people I know, that is an amazing help, and it works really good. And I know CBIT is more the American kind of way, but I'm Dutch, and we do a lot of exposure, and I think that really helps, and I think it should be noticed as well.
I think this latest generation of treaters are the giants to be. And on some level, since there are so many young people here who really don't know the contribution of some of the people who are here at the beginning of turning Tourette into an object of research, if you will, just making sure that in addition to Oliver Sacks, that we talk about some of those folks too. There's lots of people I left off who are making huge contributions today. They'll be giants tomorrow. There's plenty of time for them to get recognized by somebody else. All right. Thank you very much.